So transitioning from pediatric to adult care can be a really scary time. Rocking the boat with new doctors, a new team, and unexpected changes in managing your child's care. So here to help us navigate this transition is Dr. Georgianne Arnold. Dr. Arnold graduated from Indiana University in medical genetics from Indiana University, Purdue University in Indianapolis, and graduated from medical school at Upstate Medical Center in New York. She completed a residency in pediatrics at Northwestern University and a fellowship on genetics at the University of Colorado. Dr. Arnold is board certified in pediatrics, clinical genetics, and clinical biochemical genetics. Previously, she was faculty at the University of Arkansas and the University of Rochester. She is now professor of pediatrics and clinical research director at the University of Pittsburgh Medical Center. Her main interest is clinical research in inborn errors of metabolism. She is currently conducting numerous clinical trials for a variety of metabolic disorders and is the longitudinal project principal investigator for the National Disease Consortium for phenylketonuria. Okay, thank you. Dr. Arnold has authored more than 70 medical publications and received the Shapiro Award for the best publication by the Society for Inherited Metabolic Disorders, members in the journal Molecular Genetics and Metabolism for her paper, A Delphi Clinical Practice Protocol for the Management of Very Long-Chain Acyl-CoA Dehydrogenase Deficiency. That's a lot of words. She has presented papers at numerous national and international meetings and is currently president of the Society of Inherited Metabolic Disorders. Welcome, Dr. Arnold.
Thank you. Can you hear me okay? All right, well, I'm very honored to be here, to be asked to speak with you today. And interestingly, I learned a lot from putting this presentation together. So when we talk about healthcare transition into adulthood, I'm going to look at it two ways. One is from the patient-centered issues. Is this patient ready to transfer? And the other are the provider-centered issues, that is, what's the actual mechanism for making this happen? So adolescence has been described as the conjugator of childhood and adulthood. And in a way, it's a modern world problem because, a couple hundred years ago or more, when, by the time you were 10, you were in the factory or out in the fields. And you didn't really have time to be an adolescent. So it's a nice problem to have in some ways. But you've all, you got the newborn screen call, you got your diagnosis, you felt this way, no matter, and then things got better, and you kind of learned how things were going for your child, and then all of a sudden, your pediatric experience comes to a screeching halt. And it's like, I've got to go into the adult world now. I don't know which way to go. And so people often, feel a little lost and unsure. But don't look back, because you're not going that way. Now, the next picture, I'm sure all of the parents and the teens in the audience will recognize. You will take your Doljovi, you will take your MCT, or, you will listen to me about what I want to say to you. And, this is kind of a normal way to get through adolescence. So, what are the tasks of adolescence? What do you have to accomplish in this time period? And we were all adolescents once, and most of us don't really want to remember what a lot of it felt like. And we often remember ourselves as paragons of virtue who never had any of those two prior postures you just saw in those pictures. But things are changing. Your body's changing. You're thinking about changes in your body, your sexuality, developing your independent identity, and you need to separate from your parents, because if you don't, you'll be in trouble as an adult, and to develop your own value system. And social skills social relationships are much more complicated now. You know, if you put a couple 5-year-olds in a room with a toy, they'll just start to play. But in adolescence, those relationships get much more complicated. School's more complicated. Everybody keeps asking you, what do you want to do when you grow up? And you need to really work on your impulse control. What makes it hard? Well, you know, we don't let children drive cars until they're at least 16. We don't let them buy alcohol because they are adolescents and they don't yet have adult judgment. And so I love this quote: teenagers tend to get into a fair amount of trouble due to their omnipotent beliefs about certain situations. And I can tell you that when I was in high school, the day my boyfriend told me that he and his buddies had gone to the top of the highest hill in town, and I'm sure somebody found a beer, and would drive down the hill with the lights off without using the brakes at night. And I'm thinking, I mean, you know, he's an electrical engineer now, but like, what were you thinking? And how did this seem like a good idea at the time? But apparently it did. And then there's this push-pull. Adolescents, they want autonomy, but they also want their parents to take care of them. So there's this sort of push-pull, and they often won't go to their parents for help with things because they don't want to admit they need help. And sometimes they don't want to admit it to their parents, but sometimes they don't want to admit it to themselves. So I like this picture because you start life with both feet in childhood. And then sometime around the tweens, you start to put one foot in adulthood and one in childhood, and sometimes they switch back and forth. Which foot they're going to stand on so fast it makes you dizzy. And this tends to like embarrass parents, but you know, for me, as a practitioner, it's really kind of fascinating and wonderful to watch. And then eventually what you hope is they'll pull both feet into adulthood. But from that time in the middle, it's not even day to day. Sometimes it's minute to minute, which foot you're standing on. So what does the teenage brain look like? It doesn't look like an adult brain. There are other things that are on their minds that we don't remember, that we've worried and thought a lot about. But particularly this parental advice processor, which can spend a lot of the time firmly plugged up. So we have to figure out how to work with that and work around that. One of the major tasks of adolescence is fitting in. Where do you fit into the world? Where do you fit into your family? Where do you fit into your friends? And I like this quote. Young people experience heightened arousal in the brain regions that are sensitive to social acceptance and rejection. So you can actually put people in functional MRI scanners and give them tasks and see what lights up, what part of their brain they're using. So body image becomes very important to adolescents. If you are taking formula and medications, do you want to do it in front of your friends? Do you want them to see it? Do you want them to smell it? Or, God forbid, you have to go to the nurse's office to take it, because like most of us would rather die than go to the nurse's office at school. And, you know, your G-tube. You want to wear a bikini with your G-tube? And missing out. Not being able to do some of the things that their friends can do. Knowing that if they go to the water park all day with their friends, they're going to end up in the hospital with rhabdo. And those are all things that affect what's going on. So to you, their health is the most important thing in their head. Should be the most important thing in their head. It's certainly the most important thing in your head. But it might not be the most important thing in their head. So we used to think brain growth stopped at 6. And in fact, your brain is actually still growing and developing up until about your mid-20s. So adolescence technically goes on until mid-20s. So your brain's not done at 18 or 21. Now, female brains tend to finalize maturity in the early 20s, males in the mid to late 20s. But interestingly, adult brains do things differently. And one of the things is learning. So if you put a child versus an adult in a functional MRI scanner and give them a task to learn, different parts of their brain light up between childhood and adulthood, and that change occurs over during later adolescence. So some people who were not successful in school are very successful academically later, and then they look on that and say, well, why couldn't I have done this 20 years ago? And the answer is their brain was different 20 years ago. And of course, adolescents are more receptive to reward-based learning than punishment-based. But sometimes you can't get to that reward-based because you're stuck in the punishment phase. And so if that is happening with you, then I recommend some family therapy to kind of help get unstuck and into a place where you can get into a more reward-based system. So that's the adolescent themselves and how ready they are maturity-wise and brain growth-wise and thought-wise for adulthood. But what about the medical field itself? So how are we doing as metabolic doctors in helping our patients into adulthood? And the answer is, we could be doing better. So this paper just came out in the journal Genetics in Medicine in 2022. It's a survey of metabolic medicine in the United States for adults. And what they conclude, which we sort of knew already, was that most adult metabolic care is still occurring in pediatric settings. There are not very many adult physicians trained in metabolic medicine. And the interest in healthcare transition among physicians and clinics is robust, but who's going to teach us, and how are we going to do it? And this quote from the paper, adult providers are often not used to the amount of hand-holding the patients require. And, you know, in pediatrics, we do a lot of hand-holding for a lot of reasons. And particularly, families are young. Parents are still often in adolescence, late stages of adolescence, when their child with all these medical care needs are born. And it can be very difficult. I had a young mom not too long ago, had a child with a very serious metabolic disease. She was young, she was stressed, that's what happens, and ran out of very expensive medicine her child needed, and had a case manager, and the case manager kind of helped her try to catch up and order it. But this was at a time when the mail service had been so slowed down, and now we were at a holiday weekend, and she had no medicine coming till Tuesday. And the pharmacy told her, well, if you bring $6,000 in, we'll give you some medicine. Well, you know, how many of you, when you were, 21 and had a sick baby, had $6,000 in your pocket? And so through the Children's Hospital pharmacist, I was able to negotiate. They had a bottle that was already open. They were able to give the mom enough doses to last her through till Tuesday. And, in the adult healthcare system, that kind of stuff doesn't happen as often. So this paper actually is from Frontiers in Medicine, and it's a European paper. So what's different about the way they're doing it in Europe? They also, in general, as a specialty, don't have a standardized program. Some individual places have programs. There are more adult providers for metabolism in Europe, although still not nearly enough. So in the United States, you come into now inborn errors of metabolism and metabolic disease through genetics. But you don't actually come through it that way in Europe. It's a more independent specialty. But they thought that when they asked them in this paper to identify their significant needs, that there obviously needed to be more training for adult physicians who could then focus on inherited metabolic disorders, IMD, adequate financial resources to manage all the multiple needs of the clinics and the patients, and that they thought standardizing operating procedures could be a good thing. So I found this researching this lecture because I actually hadn't known about it before. This is GOT Transition, and it's a federally funded national resource center about healthcare transition from pediatric to adult medicine. It's not specific to any kind of disorder. It can theoretically be applied anywhere. The website, was there a handout, Kara? Yes, okay. So rather than have you trying to scribble down everything I said, the website addresses are on a handout. So you can look them up if you choose to later. So this GOT Transition program has 3 branches. One is transitioning a youth to an adult healthcare doctor, so getting a new doctor. One is transitioning to an adult management approach without changing doctors, which is probably what happens for most of you in metabolism. And the last is integrating young adults into the adult healthcare system. And I learned about the adult healthcare system managing my mother's healthcare in the last years of her life. And it's not always a warm and fuzzy place. So this program talks a lot about 6 cores of transition. So making a policy, finding ways of self-tracking and monitoring for the patients and the doctors, readiness, which is where a lot of this focuses on, then planning for the transition, actually doing the transition, and then completing it and going back and following up on what's happened. So I'm not going to really go through all of those. Most of this is going to focus on really the transition readiness part. So they actually have online a toolkit that you can look at, and it's a number of it are questionnaires, questions as well as recommendations. And in all honesty, I think that they might be a little bit utopian. So here this is for the children, the youth, 12 to 13, learn about your condition. Ask your doctor when they no longer care for adults, which I would never have thought of at 12 or 13, and maybe it's a little early. But 14 to 15, carry your own health insurance card. I don't know, when I was a pretty responsible kid, of course. I'm a paragon of virtue, but I probably would have lost it in 5 minutes when I was 14. So, don't give them the only copy. But the one down at the bottom, begin to see the doctor alone for part of the visit. So parents get offended often when we ask them to step out of the room so we can have a little alone time with the adolescent. But it's really important for them to learn they can trust us to talk about things they might not have been comfortable talking about with their parents, and to begin to develop a more adult relationship with us. So don't get offended when we ask you to step out. And then this is the opposite one for the parents. So, have your teen carry their own health insurance card. Learn about their health, learn what to do, and then they recommend starting to practice making appointments and prescriptions. And I don't know how well I would have tolerated that at 14 or 15. But again, I didn't write these guidelines, and you each know your own child and what stage of readiness they're at. Then for the older ones, by 16, 17, making doctor's appointments, making a medical summary, talking about what happens when you turn 18, and then at 18, realizing that they're legally responsible. So if you call your doctor after the child's 18th birthday to talk about them, your child has to have listed you as someone that they can talk about, because legally, technically, we can't. So you need to start thinking about that around 18 so that we have on file the permission that we can talk to you about their health care. And then, of course, this is the opposite one for the parents. Encourage your teen to make their own doctor's appointments. Ask the doctor's questions. So this is all on the web. You don't need to be scribbling anything down. So they actually have formal readiness questionnaires on the website. And, it's not necessarily that you read all the small print, but, things like, I can explain my healthcare needs to others. I know how to ask questions when I don't understand what the doctor says. I see the doctor on my own for part of my appointment. I know where to go for medical care if the doctor's office is closed. I know at least one other person will support me with my health needs, and it's a long list of questions that help you assess readiness, and I would presume you could ask these once a year and see how the answers change. And then there's a similar one for the parents. My child knows how to explain their needs, and they know where to get care. Sometimes the kids and the child's answers don't match, and that's kind of not unusual either. So, and this can help you work to kind of get on the same page. This also has a transition readiness for youth with intellectual or developmental disabilities. Now, there's a presumption, of course, that they can read this or have it read to them and make the answers. So it kind of depends on what level of disability. But it does take that into account. So I have a folder at home with my medical information. I have a copy of my care plan. I know how to fill out medical forms. I know I know where my pharmacy is. I know what to do when I run out of medicine. I have a plan to keep my health insurance. So it does take into account some developmental disabilities. So, do we have any existing paradigms for metabolic disease? And PKU is one of the more common. PKU is phenylketonuria. It's instead of not being able to metabolize fat, you can't metabolize a component of protein, the amino acid phenylalanine. It's diagnosed on the newborn screen. If you're managed well, you should be able to grow up and have a job and go to college and work in the normal world. If it's managed poorly, you can have intellectual disability. And one of the things that we found were the kids who did the best and went off to college did so well because their parents did everything for them. And so that kind of left them at a little bit of a loss when it was time to move on and go to college and move out and have their own families. And PKU is obviously, it's probably about as common as MCAD. But there was not much written. But so there actually is now a formal transition program, the Christine Tram's program. And also I found some interesting things online about Boston Children's. And I also actually learned yesterday that there is a metabolic adult provider in Vancouver, and that they actually have a formal plan where for several years around adolescence, you see both the adult and the pediatric doctor, and then they transition you over to the adult doctor more gradually. But most of us don't have the availability of an adult doctor there. So you don't have to read this little print. This is just the front page of the Christine Tram's program for PKU. It comes from Seattle. And their transition curriculum, so they've developed an adolescent transition curriculum to help juniors and seniors in high school prepare to manage their PKU independently. And it's actually 8 modules designed to be done over 2 years, so quarterly. Every quarter you come in and you work on another module in the transition program. And what's really nice about this program is it actually covers more than just disease management. So this is just a screenshot of some of the questions. There's several pages of questions. I can describe PKU. I'm responsible for drinking my own formula. I'm responsible for making my own formula. I know how many cases are with you would think about Doljovi or MCT. I know how many cases I use a month. I know who to call to order it. I can keep my own food records. So you can then rate how you're doing and where you would like to work on next. And what's interesting about this is that it is about disease management, but it's also about life skills. So after you get past the disease management questions, it's things like, I know how to unplug a sink or a toilet. I know how to reset the circuit breakers or change a fuse in my house. I wake myself up in the morning to get to school. Very practical. I know how to read a legal rent contract. I know how to budget. Very, very practical life skills, as well as disease management skills. And Boston Children's Hospital, and again, I don't mean that you should read this, it's all on their website, but they have also adapted some interesting readiness questions, and I liked those. And the address is on your handout. So they had 27 questions, which is a lot shorter than the other two that we talked about. I know what kind of medical insurance I have. I know how to prepare my own food. I know how to shop for my own food. I know the name of all my supplements and medicines. I know how to get them filled. I know how to schedule a doctor's appointment. It's a little bit more disease management specific rather than so much life specific. They also have a scoring system. And so you answer all those on the previous page, you then answer yes or no to the question. So if you said yes to 17 to 24, they're saying you probably are ready. And then 8 to 16, keep working on it. And 0 to 7, let's start working on it. And there are other pages in there to fill out. Fill out like what your medications are, other kinds of information. So it's a toolkit to have with you. So going back to summarize, when it's time to self-manage, we really need to take into account where your adolescent is in the normal development tasks. That, where they are in their thinking. What's that saying? It's amazing how much my father learned from the time I was a teenager till the time I was an adult. So kind of thinking where they are and what's important to them. And fitting in is one of the things that's really important. Separating from parents is one of the things. And so you're thinking a little bit about the burdens and tasks of adolescence and making sure your expectations are age appropriate. So, that questionnaire may say carry your own insurance card at 14, but that would have been early for me. And to realize that brains are still growing. So even though you look at your 18-year-old and think, oh my God, what were you thinking? Those things still happen. And so transitioning from an adolescent mindset into an adult mindset and into self-care from parents doing everything for you, it's not a single event. It's a process, and it's going to take several years. So you can start early. So when somebody's learning to cook, well, if they can cook, they can also measure out their MCT or their Doljovi. Work on one skill at a time because it's overwhelming. If you suddenly just sat down with your kid and said, here's your insurance card, have at it. Oh, and here's a number to the pharmacy, and here's a number to the company that supplies your MCT, and have fun. It would really be completely overwhelming. So you kind of want to work on one skill at a time. And then in the teen years, start to allow your child to develop a relationship with the clinic that's outside of you. And when you're hitting a wall with compliance, trying to kind of get inside of it. It really isn't fair to have a fatty acid oxidation disorder or any kind of chronic health problem. And I can't make it fair. But many of you may have seen that poem, Welcome to Holland, where you plan this trip to Italy, and you're excited about it, and you research all about it, and then the plane lands, and they said, welcome to Holland, you're not going to Italy. And there's a grief process for that trip to Italy. There's a grief process for not being able to spend all day at the water park like your friends are. There's a grief process for being different. But if you get stuck there, you're not going to see the tulips and the Rembrandts in Holland. So if you find yourself or your child stuck there, then we do recommend therapy to help. And some hospitals have group programs for kids with chronic health care needs. And then use your clinic to help you. Sometimes things that come from the clinic are better listened to than things that can't make it through that little plug in the parent processing device in the ear. So use your clinic to help you whenever you can. So although most of your metabolic health care for most of you is going to stay with your pediatric practitioner, most of your other services will not. Your cardiologist, your neurologist, you're going to have to transition them. The lack of adult trained metabolic providers is not going to change anytime soon. We're working on ways to try to attract people to the field, but it's still considered a little bit esoteric, perhaps. The adult care world can be intimidating and less personal. And so sometimes when you're changing your PCP, your primary care provider, there are doctors who, instead of spending 3 years in pediatrics or 3 years in internal medicine, spend 4 years in a combined program. It's called medicine pediatrics. So they come out boarded in both. Or family practitioners who then will also see patients of all ages. And that may be an easier way to go for a primary care practitioner. And then there are a few clinics I'm aware of where the metabolic docs are not allowed to attend on patients in the adult hospital. And that can be a problem. So if you're in one of those programs, now at Pitt, we're allowed to admit up to 26 without having to get on our knees and beg. And we're rarely denied older patients, but older patients have things that pediatricians aren't that good at, gallbladder disease, heart attacks, blood clots. So hopefully by the time our young teens today are in the age ranges where we have to start worrying about that, we'll have maybe a better adult care system for them. So there are published guidelines that can help you. The GOT transition program, I think, is a good place to look to make you think. I think some of it's a little ambitious in terms of age for the kids, but every child's different. There is certainly a need for age-appropriate guidelines for healthcare transitions in fatty acid oxidation disorders. And this, preparing this talk actually got me excited about maybe thinking about applying for a grant to actually do something for this like they've done with the Christine Tramp's PKU program. And then there are other guidelines like the PKU. And interestingly, I thought a good place to look would be diabetes, because diabetes is relatively common compared to FAOD, and certainly those kids all need to transition. And what I found was there really isn't. Some hospitals have developed, and pediatric clinics have developed their own transition programs and their own correlations with adult services. But mostly what I found in the literature were people saying, hey, we need to do this. So I would say it's always helpful to keep a file of the medical records, and that can be handed over when the child becomes an adult. If you're in the military, that's really important. So I don't know if you remember that last scene in Raiders of the Lost Ark where they crate up the Ark of the Covenant and put it in this government warehouse to be sort of lost forever. And that's sort of what happens to medical records in the military. And so by late teens, it's time to talk with your PCP and your specialists about how long. Some pediatricians are now seeing kids certainly through college, some through 26, but not all. Med-Peds or family practice for a primary care practitioner can be helpful. But also, don't wait till the last minute, because when I moved to Pittsburgh 12 years ago, and I actually fired the first internist and the first pulmonologist that I set up with, because they didn't work for me. And so if you get a referral and you go someplace and you find that that doctor does not work for you for whatever kinds of reasons, you need to have time to go back and set it up, and you want to transition at a time when your child's doing well. The middle of a rhabdomyolysis episode, to show up at the hospital and say, oh, well, he's 27 now, I can't see you anymore. It's not a good thing. So, don't wait till the very last minute. And then when you're working in the adult medical care system, you might have to manage your expectations a little bit. So what about the teens and adolescents who probably won't be able to self-manage when they grow up, who have intellectual disabilities? So those of you who don't have a will, you certainly need one, but if your child is on SSI and Medicaid, they probably cannot inherit from you. But you can set up a special needs trust, and you can actually even do that while you're still living, that will provide funds for a new winter coat, a hobby, even to go on vacation, and legally, but it has to be set up and done legally. You will need legal guardianship, because the day your child turns 18, everything changes. And so don't wait until they're 18 and a half and you can't get a doctor's office to talk to you. Get started early. And the other thing is to remember social needs as well as medical needs. And I learned this lesson. We learn a lot from our patients. I learned this lesson because I had a mid-20s young man with a metabolic disorder who needed a lot of help bathing and dressing. He was a very social young man, looked just like Cary Grant, a young Cary Grant. But Dad hurt his back and couldn't help him in the shower anymore. And so he went into a group home temporarily until Dad's back was better. And he absolutely blossomed there because he was bored at home and nobody realized it. And he was never bored in his group home. And he also felt like he got to grow up and move out like his siblings and be independent. And his parents picked him up every Sunday morning. They went to church, they had dinner, they spent Sunday together, and then Sunday after supper was movie night in the group home. And so he would be like, so it just started getting dark. Movie mom. Yeah, I wanted to go back to see my movies tonight. So I really learned, don't get so focused on the medical needs that you forget the social needs. So certainly keep a copy of records and then prepare in advance for your succession, because even though you're young and you're healthy, this is downtown Pittsburgh, you might step off the curb in front of a bus tomorrow, God forbid. And then sometimes they're a good place for referrals, like the ARC. There was a doctor in Rochester who worked for Easter Seals, and he was the PCP for a lot of the intellectual disability adults there. And he was wonderful. He was just wonderful. So, adult independence is a goal. And sometimes the ride there will be a roller coaster. But don't forget to enjoy it. Okay. And I almost got us back on time.
Any questions for Dr. Arnold?
Navigating the adult world is very different than pediatrics, where in pediatrics I feel like, especially in the hospital setting, people are aware of rare and complex conditions that the nurses may not have learned about in school. And moving to adult world, not many people want to listen to a 19-year-old explain what treatment I need. And is there kind of like a resource or something that we can direct the health professionals to help them understand that they can learn from the patients in this complexity, rare disease, adult world that really isn't too established in the adult realm yet?
I think one of the things that you can do is, at least for your primary care, to try to stay with somebody who still has a foot in the pediatric world, like med-peds or family practice, because yes, I mean, when you think about what do adult doctors see all day, they see old people with diabetes and high blood pressure and heart attacks, and we're such a minuscule part of now what they're doing. So at least getting, for your primary care provider, somebody who can help negotiate for you with the hospital system.
So it's a little bit different, but could you talk a little bit about the health insurance transition? If you look into any of that, there's all these archaic, weird rules, and depending on who you talk to, you get different answers. I know with our daughter, she gets. Can
you hold the mic a little closer? I need to get a little louder for me.
Sorry, I was wondering if you could talk a little about health insurance and health insurance transition, if you feel like you could, or if anyone else in the room has any advice. I think we're pretty far away from still having to move from child health care to adult health care, but is that something that should be thought about as well?
Yeah, the really good news is that the Affordable Care Act, or Obamacare, will allow you to stay on your parents' insurance till you're 26. So as long as we all don't elect people to Congress that take that away from us, that gives you a little bit more time. It gives you a little more time, but it can be challenging. I have to say, 30 years ago, I wasn't somebody who was in favor of a national health care plan like most of the westernized countries have, but I've changed my mind. I think my Canadian friends tell me they spend time writing to the minister to get rare disease things covered, like I spend time writing to insurance companies, but they tell me the difference is they're more likely to get them covered.
If you have a private health insurance, then the biggest thing is when she comes of age, then you would have to have her sign those forms so that you would be able to talk to the insurance company about any of the billing. Because even though you're the subscriber, and like my daughter's bills still come to me for her care, but she's 19, they won't talk to me about what the bill is for until she signs the paperwork that gives them permission to do that. She also has state Medicaid, and when she turned 19, then that transitioned to like a different form of Medicaid where she actually had to apply So if you have that kind of supplemental state Medicaid coverage, then you would have to look at what the rules are for your state to see, what you would have to do and what their age limits are, because they're all different depending on where you live.
So I did legal guardianship for Jake, and I just wanted to say if anybody has a child that's approaching the age of 18 and you're thinking about this, it's a process and it has to be very time specific. I'm not sure if it's different state to state, but I did it in Massachusetts and I do need to look into, now that I moved to South Carolina, I may have to make some changes and just get it legal in the court system there. But he needed to see 3 different physicians. They all had to sign off on it. There's neurological testing, involved. There's different levels of guardianship that you can get. I wanted Jake to still be able to make some decisions for himself, but have his back if he has autism on top of everything, on top of LCHAT. So if somebody tried to sell him a Ferrari, I can say, no, I didn't sign that contract, you need to rip that up. But just be mindful that it is a process and it has to start at age 17 on the dot, or 17 and a half, I think it was, and be done 2 weeks before age 18. I had to get an attorney. It was a couple $1,000s, but I did a will and all that stuff at the same time. But it's something you probably need some help with. It's not easy. It's definitely a pain in the neck, but worth doing it.
Any other questions for Kevin?
Dr. Arnold, can you, or something to think about, also if we prepare something to transition kids, prepare the parents. And I think things like being warned about things like when they're not going to be capable what you do, but also the reality that the night they turn 18, you lose 100% access to their medical records online. So that's, I guess you knew that was coming, but were we prepared for that? I think that one thing to be addressed as we continue to look at this is, parents, here's what you need to know that's really about to happen, because whether you all like it or not, the night they turn 18, the entire world changed. And so, I don't know, just a thought to make sure we're addressing how to prepare the parents for those realities, because we've done so much for so long. We can transition them, but suddenly we literally are cut off unless we've taken the steps to have access.
Yeah, interestingly, the GOT transition program was actually set up, if you read into it, a lot for kids with, in the foster care system and stuff, who, when they turn 18, they don't have anybody to rely on. So it's very focused on that. You're turning 18, get a clue. But yeah, it's true. Technically, if the day you turn 18 and you open up your child's med record online, it's not going to be there unless you have permission. And technically, we can't even talk to you without the child's permission. Well, now the young adult's permission.
Any other thoughts or questions?
There's another resource that I like very much, because I knew or know the person who started it, and he's now moved on, but Exceptional Parent Magazine. They were really in the vanguard of trying to advocate for, there actually is a medical specialty of adult care providers for individuals with disabilities, and most of your kids won't qualify for those programs, but they have all of the a lot of the advice on how to find these kinds of individuals and help you navigate that. So take a look at it and actually let me know what you think, because I've sort of fallen away from it since the previous publisher stepped down, and I'd be interested to see if you think it's still as good as I used to think it was. And this will give me an impetus to actually go back and look at it as well. The other half of this transition is of course us, the care providers. And as Dr. Arnold mentioned, we're not age limited in our ability to see kids. We are we are not pediatric specialists. We are medical geneticists, and we are trained across the age spectrum. But 75% of the metabolic specialists in this country work in a pediatric care center. So that makes it difficult. What it means is that as your kids get older, we have to identify specialists in the adult world who are willing to take now young adults with these specialized problems. And I will tell you, it's as difficult for us as it is for you. Those names I have found change almost yearly, if not every other year. We find somebody who says, yeah, I'll take them, and then after a while they say, I'm sorry, I'm just too busy. Because our patients take a lot of time, and that's very difficult. So it's really important to work with your care provider team, who should have transition programs in place to handle this. I start talking to kids about their diseases directly before they hit their teenage years. When they hit their teenage years, I talk to them first, recognizing that the parents are in the room. And then as they get closer to 18, I say, is it okay if your mom and dad stay here? Would you like them to sit outside? And if they say, I'd like them to sit outside, is it okay if I bring them in at the end so that we can kind of review what we've talked about? Because, technically they're still your parents, and they're still in charge. And I get very little pushback on that. Most of the time the kids go to, yeah, they can stay, I don't care. But these are subtle things as a care provider that, in addition to some of those very formal procedures that Dr. Arnold outlined, start making a difference to the teenager as they start approaching independence.
Anyone else? Thank you so much, Dr. Arnold. We appreciate you.